The topic for today is approach to Yqrs tachycardia, and let me see how best I can go through this and what you can take home. I hope some points are taken home. And the schema for the presentation will be like this. What is Yqrs? What are the differential diagnoses? Why should we differentiate between them? How to differentiate between them? Some examples to look into the criteria, and then finally a few slides on the management, which includes medical management, ablation, and also device. So our focus predominantly will be in differential diagnosis and how to not miss a VT. So what is Yqrs tachycardia? Written with a rate of more than 100 beats per minute and a QRS duration of more than 120 beats per milliseconds. And I'm sure you all know about it. When we call it ventricular tachycardia, 3 or more consecutive ventricular beats with rate of more than 100 per minute is VT. When we call it supraventricular tachycardia, it is a tachycardia requiring participation of structures above the bundle of his. So this is the basic stuff. Why should we identify the mechanism, whether it is a VT or SVT? It is very important to avoid diagnostic errors, and which can lead on to therapeutic errors, and then, as we all know, dangerous sequelae. For example, if you diagnose a VT as SVT and give verapamil or diltiazem or adenosine, we could land up in trouble. And what is the diagnostic likelihood? Suppose you have a broad QRS tachycardia, broad complex tachycardia, and you blindly say this is a VT, you will be right in 80% of the scenarios. Suppose the same ECG, Yqrs tachy, you have, but you know a little more history that the patient has a structural heart disease or a past MI, then your likelihood of diagnosing a VT is 95% without further investigation. Now, there are some clinical clues, as already mentioned, one of them. At age about 35 years, the positive predictive value is 85% for a VT. Suppose the palpitation is for more than 3 years, then SVT is more likely. We should remember that idiopathic VTs can last for many years and can be quite benign and less symptomatic. Yqrs tachy for the first time after MI is very often VT. Likewise, structural heart disease like coronary artery disease, dilated cardiomyopathy, hypertrophic cardiomyopathy, all point towards a Y complex tachy to be a VT. A person taking antiarrhythmic drugs also points towards the tachy being a ventricular tachycardia and a supraventricular tachycardia. There are examples where patients are on tricyclic antidepressants and which can prolong the which can prolong the QRS intervals, and SVTs can appear like a VT, and that should be the drug intake history is very important, and during investigations we need to look into the drug levels, etc. Patient who is already on an ICD or a pacemaker, it will help us a lot in determining the etiology, as I will show in future slides. Now, clinical clues going into physical examination. If the patient is hemodynamically stable, we can have a look at the JVP. We can see cannulae waves, and if you have a keen eye and a keen ear, you can listen to varying first heart sounds as well. Hemodynamic instability is very likely to be a VT, but it is not always so. Even SVTs, which are very rapid, can cause hemodynamic instability. So what are the differential diagnoses? When we see a wide complex tachy, first of course is ventricular tachycardia starting from the ventricles. Next is an antidromic tachycardia where the atrial impulses travel down the axillary pathway and go up the his Purkinje and AV node, or it may be any type of an SVT, whether it is a AVNRT or an ATAC, which conducts in a pre-existing bundle branch block or with an aberrance, rate-related aberrance. So this table gives you the differential diagnosis. As already mentioned, antiarrhythmic drugs like class 1A or class 1C should be taken into consideration. Hyperkalemia also causes broad complex tachy as one of the issues. So the ECG is the cornerstone in the diagnosis of QRS tachycardia. Now, anybody can diagnose this to what it is. The QRS need not always be so broad. The AV dissociation need not always be so obvious, and concordance need not always be present. So if a typical ECG like this comes, anybody would say, yes, this is a VT. Need more knowledge to diagnose a wide QRS tachy in majority of the conditions. So wide QRS tachycardia, this is an algorithm that is very commonly used, and it is from the textbook Brownwald based on a lot of studies. We first have to see whether it is regular or irregular. If it is irregular, it could be atrial flutters, atrial fibrillation, or atrial tachy with variable conduction and pre-existent bundle branch block or PXL. We will not touch upon this too much. I'll definitely show an ECG. If the wide QRS tachy is regular, we need to see how the sinus rhythm ECG is. If the SVT, and then if it is identical to the sinus rhythm ECG, then it is SVT with bundle branch block or an antitonic tachycardia like in a etc., where there will be LBVD even at baseline. Now, if there is a previous history of MI or structural heart disease, we already said VT is more likely. In a regular wide complex tachycardia, if the one-to-one AV relationship is not there, it will help us a lot. If A rate is faster than the V rate, we know it is ATAC or atrial flutter. If the ventricular rate is faster than the A rate, then we know it is VT. But AV dissociation need not be very obvious. So in many instances, we are not sure of the AV relationship, or there may be one-to-one AV relationship, especially in the young, or when the VT is low. Yeah. So when it comes here, so in this scenario where one-to-one AV relationship is present or unknown, then we go on to QRS morphology in the preclinical. Typical RBVB or typical LBVB suggests a supraventricular tachycardia. And then if it is not so, there are characteristics which point to ventricular tachycardia. And in the presence of RBVB or LBVB pattern, there are QRS morphologies and the axis that I'll be touching upon. It is generally true that if you can see P waves, you can usually diagnose the rhythms. What is important is, in the diagram shown, there is a broad complex tachycardia, but it is very important for us to realize there is a premature P. In the presence of a premature P wave preceding the onset of wide QRS tachycardia, this favors a supraventricular origin of that rhythm. So AV dissociation is characterized by atrial activity that is independent of the ventricular activity. So the atrial rate, if it is less than the ventricular rate, it is a VT, and atrial rate more than the ventricular rate is SVT. Like in this diagram, we see that there is AV dissociation, there is one-to-one AV conduction, right? So we need to make out whether there are dissociated P waves or not. How do we make out? What is a dissociated P wave? The PP and the RR intervals are different. So here you see the P waves are going on at regular intervals and the RR are at different rates. But you may not be able to find a definite relationship between the P and the QRS. There is no association. And the PR intervals may vary. The presence of P in some, but not all QRS complexes, as in some of the ECGs I'll show later, points towards AV dissociation. Why is it so? Because the P wave could be hidden in the QRS complex. Then there are certain characteristic beats like the fusion beats and capture beats. What is the fusion beat? A ventricular fusion beat occurs when the ventricle is depolarized by a supraventricular when the ventricle is depolarized by a supraventricular impulse and the ventricular ectopic focus at the same time. So the resulting QRS is a hybrid of both of them. So the fusion beat is diagnostic of AV dissociation and therefore of ventricular tachycardia. But it is found in fewer number of patients, so sensitivity is low, but the specificity is very high. Like in this ECG strip, there is a wide QRS tachycardia, and there is two capture beats or sinus beats in between, and in between you can see that there is a mixture of QRS between the VT and the sinus. This is a fusion beat. Okay, and in the lower strip, there is a sinus tachycardia with the Rbc morphology, and suddenly there is a broad complex tachy, and the sixth beat you can make out is fused. It is neither the sinus nor the VT. This is called a fusion beat. So capture beats or the Dressler beat, QRS complexes during the wide QRS tachy that are identical to the sinus QRS complex. That means it is very narrow. Implies that the normal conduction system has momentarily captured control of the ventricular activation. So these two beats, fusion and capture beats, are more commonly seen when the tachycardia is slow. For example, this ECG shows a regular monomorphic wide QRS tachycardia or wideish QRS tachycardia with RBBB leftward axis. Now suddenly you see again the sixth beat is a narrow QRS tachy. This is a capture beat. The sinus impulse is able to penetrate and capture through the His-Purkinje system, causing a narrow QRS like the sinus. So this is a capture beat. And with regards to wide QRS tachy, V1 is a very important key to differentiate between left bundle and the right bundle morphology. The QRS complex duration of more than 120 milliseconds with predominantly negative terminal deflection. It's not the initial deflection, negative terminal deflection in lead 1 is LBBB morphology. A positive terminal deflection in V1 is right bundle morphology. So, is the wide QRS tachy that we are dealing with a VT or a supraventricular tachycardia? There have been various algorithms, there have been combination of criteria which has been found to be better, and with all this experience counts. And before 1991, only 1/3 of the cardiologists were able to diagnose VT correctly when given with a wide QRS ECG. It was Professor Marriott in 1970 who showed in right bundle branch block shaped tachycardia. That means a positive terminal deflection in V1. Presence of a QR or a monomorphic R in V1 strongly argued for a ventricular origin of the tachycardia, while an RSR- pattern suggested a supraventricular origin. So this is Professor Valens, who recently we lost, and at the age of 84. In 1978, he wrote a very beautiful article in American Journal of Cardiology, how to distinguish VT from SVT, where all these criteria are enumerated. AV dissociation, which is 100% specific, capture or fusion beats, which are 90 to 96% specific for VT, negative or positive concordance, which is highly specific, and tachycardia QRS, more narrow than the sinus QRS. For this, I'll touch upon this again. So in this, he also mentions about right bundle branch block configuration and left bundle configuration. In the presence of right bundle morphology, a QRS width of more than 140 milliseconds with a left axis deviation is favoring a VT. Whereas in left bundle configuration, a QRS width which is more than 160 and right axis combination points towards a VT. Now, in our RBV morphology, in V1 and V6, we need to look into specific criteria. A QR morphology or a monomorphic R or a rabbit ear, left ear taller than the right in V1 points to a VT. And a right one taller than the left is usually seen in SVT with aberrancy. And RS ratio less than 1 for a
and it's 0.1. There is something more in the blood of and there is one more that you jump and English are in one like that calibration. This is the English are repeated as
is RS, whether it is RS or a small r in a big S and big R in a small s. Then you go to the next step, and when you magnify and measure from the beginning to the nadir of S, if it is more than, here it is 120 milliseconds, then this points towards a slow conduction in the myocardium. That means it has to be a VT. If that is not there, then you go to the next step and see whether there is AV dissociation. If there are more V's than the QRS, there is no relationship between the P and the QRS, then this is diagnostic of VT. If suppose even this is not discernible, there are scenarios where we may not be able to make out, or the tachy can be slow with 1-to-1 retrograde conduction. Then we move to the next, that is the morphology criteria, as already alluded to in the RBBB context. A QR or a monomorphic R or a left gravitier sign in V1 is pointing towards VT. And in left bundle morphology, this is the Kimball criteria I mentioned. And V1 R wave more than 30 milliseconds, notch on the downstroke, this is Josephson criteria, and beginning to the end is more than 70 milliseconds, or any Q in V6, these point towards a VT. Later, very simplified criteria of AVR criteria or Vericay criteria was published, which said initial monomorphic R points to a VT, very high specificity. If it is not, look at the small r or a small q that is there. If the width is more than 40 milliseconds, it is a VT. If that is not visible, then you see if there is a notch on the downstroke of a negative onset, predominantly negative AVR. If there is a notch, again there is a high likelihood of VT. If it is not discernible, then you see the beginning 40 milliseconds, the height in the first 40 milliseconds, and the height of the last 40 milliseconds. If the ratio is less than 1, again it is highly suggestive of a VT. But the specificity is not very high, but reasonable. Then came the ultra simple criteria by the Joseph Brugara group by Pava et al. R wave peak time in lead 2. Only one lead 2, duration of onset of QRS to the first change in polarity, either the nadir or the peak of R wave in lead 2. If the R wave peak time is more than 50 milliseconds, the likelihood of VT is very high, with a positive likelihood ratio of 34. Let us look into what they quoted in their studies. So this is lead 2. If you measure, this is the beginning of the QRS here to the peak. If it is more than 50 milliseconds, here it is 80, so it's a VT. It's a right bundle, right axis tachycardia. Whereas in the second example, right bundle, right axis tachycardia, you see that the R wave peak time is less than 50 milliseconds. It's 30 milliseconds. So this is an SVT with aberrancy. So this is a very good criteria which we can see later. Always look at the sinus ECG. Similar QRS complex suggests a SVT. If suppose VT is RBBB morphology, but the sinus complex is LB morphology, contralateral bundle branch block pattern suggests VT. Suppose the patient has a sinus rhythm with a QRS with a LBBB pattern or intraventricular conduction delay of 150 milliseconds. Now you have a wide QRS tachycardia of 140 milliseconds. That again says this origin is from a ventricle and it is a VT. So wide QRS tachy narrower than the baseline ECG suggests a VT. Look for the PVCs, that will tell you where it could be coming from. Evidence of previous MI, as already alluded to. Evidence of any other structural heart disease, already touched upon. So remembering the basic concepts, if the VT is towards the septum, then lead 1 will be positive, right? And also the inferior leads, if based on whether it is basal or higher up or lower down, the inferior leads can be positive or negative. So septal, lead 1 positive, lateral wall, lead 1 negative, because the forces are going away from the lead. Apical, again you expect the inferior leads to be negative, and if it is basal, superior, the inferior leads are positive. These are basic concepts, and if the exit side or the focus is anterior, you expect a negative concordance. If it is posterior and basal, you expect a positive concordance. So there are some pitfalls and caveats. Most of these studies did not include idiopathic disease, unfortunately. So they fare less specific in this group, like RVOT VTs, FSTR VTs, etc. Bundle branch reentry VTs can be falsely diagnosed as SVT, and pre-excited tachycardias can also be diagnosed as VTs. So these are some few pitfalls that we have to remember. With this knowledge, as already said, this is a typical idiopathic left ventricular VT. You will not be applying any, for a tachycardia, to have a right bundle and a left axis for a supraventricular tachycardia is very unlikely. Supraventricular tachycardia with aberrancy of RBBD type would have a right rabbit ear taller than the left rabbit ear, number one, and the axis would be rightward than leftward. And negative complexes in V5, V6, all these point against a supraventricular tachycardia. So this is a VT, even though it appears relatively narrow, right? So RBBD leftward axis, think of a VT, which is idiopathic or a fascicular VT. And this is again another case of left bundle, left axis. You may say, okay, left bundle, left axis, it is again, intrinsic deflection is relatively less, so it is a left bundle aberrancy. But left bundle, left axis, before we conclude that it is supraventricular tachycardia, if you can see the P waves here is missing here, that points towards a AV dissociation. This is actually a prototype of a Mahem tachycardia. It's an atriofascicular tachycardia, which has, these are two scenarios where you may falsely diagnose, or miss a diagnosis of a VT, or, following the traditional criteria. So fascicular VTs and this one, and also pre-excited tachycardias. So good. So there are some criteria to differentiate VT versus pre-excited SVT, and you can look up on it later. So how do we, suppose you get a patient like this in the ER, what do? We of course see whether the patient is hemodynamically stable. If stable, then we evaluate, we do a ECG if we have time, then we do the blood gases to make sure it's not a metabolic cause that is causing the broad complex tachy, and electrolytes are checked, drug levels, if suppose the patient is on digoxin or other drugs, because digoxin can cause after depolarizations and VTs, and angiogram, if indicated, to be always ruled out, as a coronary artery disease is the underlying cause for many of these broad complex tachyes, and MRI, PET for inflammatory pathology, cardiac biopsy when appropriate. I'll again touch upon this later. So characteristics of VT in structural heart disease. In the present, prototype is a myocardial infarction, for example. There is a scar. In such cases, we usually get a sustained monomorphic VT, right? Sustained monomorphic VT. In non-structural heart disease, we, for example, channelopathies like Brugada or long QT or short QT, we develop VF suddenly. And any presence of scar, for example, underlying substrate could be anisotropic conduction in scar tissue, means in the scar tissue or around the scar tissue, there can be remnant tissue or channels which can be slowly conducting and form a nidus for re-entry. And borders of patch used for VST repair, like in a TOF or a regular VST, they can develop VTs. Bundle branch re-entry VTs, post-valve replacements are also known. And the mechanisms in structural heart disease is predominantly re-entry, and focal automaticity is also seen, but in a small percentage of ischemic cardiovascular patients. And suppose a patient is on digoxin, etc., triggered activity is also a cause of ventricular arrhythmia. So there are some clues on resting ECG I've already alluded to. I'll not touch upon this again. And what imaging should we ask for? Echo, always a must in the emergency setting, on any setting, can reveal the underlying pathology and also the ejection fraction. And for example, bundle branch reentry VTs are more common in patients who have low ejection fraction, whereas scar-related VTs can occur even in patients with a good ejection fraction. And there can be a tachycardiomyopathy, which can normalize after ablation, etc. And coronary angiogram to rule out ischemia, cardiac MRI. Scar burden will be known, presence of scar and location, like whether it is subendocardial and mid-myocardial or subepicardial, and is it following the coronary territory or not, etc., can be known by MRI. It only needs a very well-trained, radiologist to help us with this. And ARVC can be diagnosed, HCM can be, non-compaction is a underdiagnosed cause of VTs, helps understand the anatomy in congenital heart diseases, and also useful in reversible ischemia assessment. Also, a word on PET-CT, positron emission tomography, or FDG PET. Hotspots are seen. These are areas of increased uptake which reflects inflammation, typically seen in inflammatory myocarditis, whether it is tuberculous or in sarcoid, it can be seen. To differentiate, we can do a cardiac biopsy, and this can help us guide. Suppose the the hotspot is not at all there in the heart, but it's there in the lymph node. You can go to the lymph node rather than doing a wasteful cardiac biopsy, and it also helps in follow-up by helping us tell whether there is whether the inflammation has subsided or not based on the immunosuppressives that we use. So with this knowledge, I think we should go into the ECG proper. We have all dealt with this. So a case example, importance of sinus rhythm ECG. As said, this is a patient who presented with a wide complex tachycardia, 2 episodes of near syncope 1 year apart. What was done was 2 times angiogram. If you see here, you can easily say that the QRS is very wide. It's a left bundle branch morphology. There is some suggestion of AV dissociation. So this has to be a VT. Even the R to S is quite tall and quite long. This is a VT. Now, what is the confusion? Look at the sinus rhythm. This patient a year ago, after conversion of tachycardia, showed this morphology. So ST elevation, diagnosed as acute coronary syndrome, started on all the drugs. Angiogram was normal, so diagnosed as Minoka, and and then again the second ECG a little earlier had this pattern. What are we missing out? This is a type 1 Brugada pattern. There is ST going, J point elevation, and T inversion here. If only they had gone one space higher, even V1 would have probably shown. Brugada pattern is diagnosed when the J point is elevated more than 2 millimeters with a coving ST and a T wave inversion in V1 or V2. In more malignant patterns, it can be present in infralateral leads also. So type 2 Brugada pattern, please don't miss it. If you see something, ischemic ST elevation is convex upwards, this is concave upwards, that should tell you, especially when angio is normal, you should probably send these cases to an electrophysiologist who can do a drug challenge and diagnose appropriately. ICD is the therapy and not drugs. This young boy, a 13-year-old child, was brought by his parents. He just could not run. Any time he runs, his heart rate jumps and he feels giddy, extreme giddiness. And what do we see? This is a bidirectional VT going on, and this is a CPVT or catecholamine dependent polymorphic VT. Of course, this is bidirectional, and this is enough for me to diagnose. This is a condition which is due to a mutation in the rhinodine receptor, which is an autosomal dominant mutation or autosomal recessive mutation in calsequestrin gene. And what happens is there are sudden leaks from the sarcoplasmic reticulum into the cytoplasm, and there's a calcium spike, and that causes instability and depolarization, which during exercise is unabated and causes even polymorphic VT. What did I do? I just started metoprolol, hyped up to 50 mg. He's a very thin-built fellow, absolutely fine. He cannot afford ICD, otherwise that's a good idea. This is another patient who was assured just 2 months before it was the patient presented to me, and it was assured that ECG is normal, echo is normal, and was sent back. The history was palpitations and giddiness. And 2 months later, she presents with frank syncope, and this is how the ECG was in our ER. Sorry for the disturbance. In the ER, all this happens. What do you think it is? Is it RVOT-VT or is it an arrhythmogenic right ventricular dysplasia? I'm sorry, I've not touched it. It's not a quiz. It was supposed to be, but then I thought I'd teach. What do we see here? There is a monomorphic regular VT with LBVB morphology, transition in V3, very rapid, lead 1 and AVL negative. Okay, so 2-3 AVF are very tall. That means the QRS, this VT is arising from somewhere near the summit or outflow tract of the right ventricle. It is arising from the right ventricular outflow tract and somewhere posteriorly or rightwards. This is lead 1 is negative, so it is anteroseptal very likely, and this is a typical outflow tract VT, which should be ideally treated with drugs first, and if refractory, ablation. What did I do? This is the first documented episode. Started on beta blockers, hiked up to 100 mg. It's 1.5 months, absolutely no PVCs or giddiness. So, of course, if you look into the guidelines, a VT with syncope, even catheter-directed ablation is class 1 indication. I have conveyed this to the patient, and if there is a recurrence, you can always ablate. So, outflow tract tachycardias are diagnosed by inferior axis, monomorphic, transition in V3 or V4. This could also be V3 transition, could be left ventricular outflow tract as well. But only on EP study we will realize that. And this is how we manage. And such patients, that's to show the role of drugs. 1.5 months, patient is fine. If recurrence, do an ablation. How do we differentiate ARVC VT, which is more dangerous? It is sinister compared to relatively benign RVOT VT. There are very few reports of RVOT VT killing a person compared to ARVC. So now there are some ECG criteria. Lead 1, if the QRS complex is more than 120 milliseconds, it says there is a delayed conduction, so it is likely to be ARVC. If the QRS transition is very late, I told you here it's in V2 or V3 if it is left-sided, V3 or V4 if it is right-sided. So if it is V5 or later, that points towards a substrate, so ARVC is likely. Early onset QRS in V1. In RVOT VTs, it is the other leads which have an earlier onset than the V1. And here in ARVC, it is a V1 which has the earliest onset. And notching of the QRS, you see all these notching of the QRS, these point towards ARVC. These are 4 points which have been shown to be statistically very significant to diagnose a malignant from a benign VT. So, if suppose all these are done and you cannot diagnose, there is AV dissociation is not obvious, then of course we need to, or you have a doubt whether it's a VT or a SVT, or you want to get rid of the symptoms, then you go to the more invasive things like EP study. This is how we diagnose. We put catheters, we place the catheters in the atrium, in the coronary sinus, in the right ventricle, etc. And then here is a tachycardia, broad QRS tachycardia with very clear more ventricle than A. But why on sinus ECG we could, during on ECG we could not make out AV dissociation was because if you see here the P wave is always falling within the QRS complex, so it was very difficult for the physician to make out. Okay, so but on EP you see it is not associated, it is coming all over the place. So AV dissociation is present. We do land up in scenarios where there is a wide complex tachy and there is one-to-one association. So how do we then do? We then dissociate the A from the V by rapidly pacing. Now the A is being paced much faster than the ventricle. These are things that we do to prove that it is a VT. Once diagnosed, then you do a 3D mapping. You go behind these potentials which are fractionated and much earlier than the QRS on the surface. These potentials, and then you pace and find out that it is exactly matching the VT morphology or entering in reentrant tachy, and then burn and ablate and return the patient to sinus rhythm. You get rid of the tachycardia. This was the LVOT tachycardia that was ablated. We can, land up in more confusion. What are the differential diagnosis of a wide QRS tachycardia? We touched upon it could be SVT with aberrancy. It could be SVT with it could be an antidromic tachycardia, okay, or it could be a VT. Now, how do we differentiate? Once we place the His bundle catheters, we in SVT with aberrancy or a pre-existent bundle branch block scenarios, we always get a positive HV. The H is first coming here, followed by the QRS. H comes first, followed by the QRS, and the HV interval is maintained. Then you know it is a SVT with bundle branch block or a aberrancy. Now in this scenario, the H is coming almost on time or even within the QRS. This is possible in a few scenarios. One is a ventricular tachycardia. Two, where the His will not be in the earlier part, will be much more inside. I don't want to go into the EP part of it because the crowd is mixture. We can, that's a different audience. So His will be much inside the QRS. In VT, in an antidromic tachycardia means from the A, the impulse travels through the axillary pathway to the ventricle and then back. That's antidromic tachycardia. Or scenario where there is a supraventricular tachycardia and also an axillary pathway, so which is a bystander pathway. In bystander pathway, the tachycardia, the bystander accessory pathway is not part of the circuit but simply conducts it to the ventricle, causing confusion. So in such scenario, what we do is we do maneuvers like giving atrial impulses when the His is already activated, and this is a His refractory APC or a premature atrial complex which blocks the axillary pathway, but the tachycardia continues. If the accessory pathway was part of the tachycardia, if the pathway blocks, the tachy should have stopped. But here you see the tachycardia continues at the same cycle length of 300 milliseconds. That means, and the VA is so small and the HV is now positive, it all points to a supraventricular tachycardia with a bystander axillary pathway. So EP study helps a lot when the diagnosis is not certain and also to cure these patients. So this is another case. What do we do here? I will take you along. There is a sinus ECG and there is a VT ECG. What do you see? QS V1 to V6. This is negative concordance. It is highly suggestive of a VT. Where is it coming? And also see that AVR is monomorphic and upright. Monomorphic R, Rbc criteria, is already a VT, right? Inferior is 2-3 AVF is negative. That means it is coming somewhere inferior. V4 to V6 negative means it is coming apical. So apical inferior location is this origin of this tachycardia, and QRS is relatively narrow. That means it is more septal. Okay, what could be the reason? Sinus ECG after shocking the patient. This was an old ECG of mine, and there is incomplete right bundle branch block and T wave inversion V1 to V3 and an epsilon wave. It need not always be in V1. Take care. If you enlarge and magnify even in V1, you can see. If you miss it in V3, also very clear epsilon wave is seen. That is suggestive of ARVC. What is the triad of ARVC? Arrhythmogenic right ventricular dysplasia or cardiomyopathy. The RV inflow is involved. I did not. The RV inflow is involved. This is the Braunwald textbook image, and this is the 3D mapping that I have done. This is the tricuspid annulus, and the gray is the scar. RV inflow means next to the tricuspid valve. RV outflow means below the pulmonary valve, and the apex is not seen, even that was scarred. All the three areas was scarred. This was the ARVC. If you look at the exit here, it is apico-inferior and LBBB morphology. The same patient had another morphology with a different QRS complex, but still apico-inferior, but with a RBBB, means it is exiting towards the left side also. So the scar can exit left or right if it involves the septum. ARVC can also involve the left ventricle in a significant minority. And again, AVR is positive. If you see here the criteria of lead 2 criteria, in some other ECG I will show. Now, recurrent exertional palpitations and exercise intolerance. Never neglect any patient's any symptom. Okay, it helps really to go a little deep, spend a little more time and investigate further. And if you cannot, send it to the electrophysiologist or a heart failure specialist, and they will do something more. Recurrent exertional palpitations and exercise intolerance. Holter high burden PVCs, and I did a CMR which showed ARVC. Genetic study, because he was a 14-year-old child, genetic study came strongly positive for all the mutations, gene mutations were positive, and then he was not keen on ICD. ICD is the right thing because he has exertional palpitations, and RFA was performed, and he did very well at 6-month follow-up. And this is how we do. We take a pericardial stick and we access the pericardial space. We do a 3D mapping, and we go to the area where we are earlier than the QRS, and here we have a reasonably good unipolar signal, and the local potential is about 35 milliseconds earlier. And as you can see, I'm doing an angiogram to be sure that I don't injure. That's the first rule of being a doctor, do no harm. So, and then we start the ablation and there is absolute silence. This is how we do. This is another case of white QRS tachycardia. 26 years, I'll end my talk in a few minutes and then we can go for the quiz. 26-year-old gentleman, high burden PVCs. For that high burden PVC, they have started on amiodarone and beta blocker, with which the LV ejection fraction has improved from 25 to 40%. Even now it is less, right? And still has 21% PVC. So here we do a 3D mapping, activation map is done. There are different types of mapping we do, pace map, activation map, and reentrant circuits, entrainment map, etc. And these are all focal or micro reentry etiology. So here we start, look at this unipolar signal, which is so beautiful, and compared to the surface QRS, I'm 50 milliseconds early, and the first burn destroys the PVC and sinus rhythm is restored. These are tachycardiomyopathies, and these are people who will improve their ejection fraction. Now, based on the knowledge we have gained, let us revise some ECGs. What is this ECG? Is it basal exit or apical exit? This is not a basal exit. Why? If it is a basal exit, we get a relatively significant R waves in D5, E6. In apical exit, there will be deep S or a QS complex in a apical exit. So that says it is apical. And 2,3 AVF is deep negative. Monomorphic deep negative suggests that it is coming somewhere from the inferior surface of the most inferior surface of the myocardium. So inferior apical. It could be from the crux or it could be from the moderator band also. Usually these crux VTs have a pattern break on the ECG, which is not seen. This is very likely to be a moderator band VT, and This again, you can see AVR is monomorphic, and this is how we analyze an ECG. Negative concordance, AVR positive, deep negative, suggesting the most inferior part, probably the crux or more apical, and the crux also has basal crux and apical crux. Apical crux can have negative complexes, but QS, it could be a moderator band also, which is very close to the same area. This is a very interesting ECG where you're seeing a bigeminy. They can also have VTs, but this is a bigeminal ECG, very narrow. That means it is coming closer to the septum. QRS width close to the septum. QRS is negative here, that is, it is, and then suddenly V1 is deep negative, V2 is positive. This is a pattern break. Pattern break is a crux V2. And 2,3 AVF is deep negative. 2,3 AVF is negative, so it is most inferior. It is the crux. And V2 to V6 is positive. That means it is not apical but basal. In the crux, there is a basal part where the impulses or the the conduction is towards the V2 to V6, and apical it is away from V2 to V6, and this is how we analyze narrow QRS closer to the septum exit 2,3 AVF, and this is again a crux VT, a basal crux VT. Now this is a ischemic heart disease in a patient with ischemic with old infralateral MI and on an ICD for LV dysfunction. If the red is all the scar and the pink or the purple is the healthy tissue, and these islets are all the black ones are the areas where there were fractionated potentials, which could be part of the circuit. As I initially said, these living channels, muscle tissues in the dead myocardium form the channels for the VT. And the ICD is, if you pace from the ICD, you know there are late potentials, that is potential coming after the QRS, and during the VT you see mid-diastolic potentials. We do entrainment and see whether we are at the exit, isthmus, or the entrance, etc., based on certain criteria, and we ablate these channels and terminate the VT and bring the patient back to sinus rhythm. This is the utility of 3D mapping. This is how it is. The patient is already on an ICD, and we are ablating somewhere inferior septal and also lateral, and this is the coronary sinus catheter. This is the ICD in place. This is how we do the cases. What is the role of devices? Suppose a patient with pacemaker has syncope. You see here, this is diagnostic. There are more V's than A. This is a VT. Next, we implant an ICD. This is how an ICD looks. There's a high voltage coil here. There's a dual coil ICD, likely to be a Medtronic one. And then this is another case where the device immediately, this is how ICD helps. Detects a VT, gives the ATP. What is ATP? If the tachycardia is at 150 or 160, then the pacemaker ICD paces 10 or 20 beats earlier, faster, and tries to get into the circuit and break the tachycardia. This is called anti-tachycardia pacing, and terminate the tachycardia. Likewise, if those ATPs or anti-tachycardia pacing do not work, they directly go and give a shock. This is a shock that terminates. You can see here 41 joules, and tachy terminates. Now, approach to wide QRS, another clinical scenario. This lady is a young girl, 18 years, a few more ECGs. I hope it's okay. So, 18-year-old girl, she presented to me in 2013. Recurrent syncope and pre-syncope for 1 year. Not diagnosed, and echo showed moderate LV systolic dysfunction. And we were lucky to pick up this ECG, and cardiac MRI was done, which showed an ejection fraction of 39%. So first, when this ECG came to us, there is a deep negative in lead 1, which should point that there could be an epicardial exit as well. But anyway, being young electrophysiologist long back, everybody goes through this. There was a VT, monomorphic. We said, okay, let me take up for a EP study and ablation. On the table, we induce, this is the extra beats, ventricular extras, and we induce the ventricular tachycardia, and we also do rapid pacing and terminate the tachycardia as well. This proves that there is a re-entry because you are able to induce, you are able to terminate with pacing, and ATP would do great in such cases. However, when we did the EP study, we used various morphologies of VTs, very rapid VTs. So what does this mean? Means the substrate is quite significant, multiple exits are there, and the VT ablation is likely to not give very good results. And then we went ahead with the MRI. MRI showed a typical mid-myocardial scar here. This should have been totally black if there was no scar. And this is a typical mid-myocardial scar, and these are patchy scars, not conforming to territory and coronary territory. And this is classical of a cardiac sarcoid, or even tuberculosis can present in similar ways, but the MRI presence of scar is in different patterns. The problem with this is it can present, you see this septal scars, these fellows can present with very narrow QRS, and this can be a septal VT which can be misdiagnosed as a supraventricular tachycardia. So it is very important for EP guys to be involved and to study it further. We went ahead. How did we evaluate this patient? We did ACE levels, which was elevated. We did MON2, unfortunately, that also came positive. And past history is very significant. Mother succumbed to probably PTB. There was no records. And when the patient herself was an infant, probably mother also had sarcoid. What did we do? We implanted an ICD. As there was no obvious lymph node for FNAC or a biopsy, and I performed a right ventricular myocardial biopsy. A septal biopsy was done. We did a few pieces, sent it for study, which turned out to be normal. So cardiac biopsy, which we did in 2013, was normal because only about 20% of them will come positive in sarcoid. Why? Because the scar is mid-myocardial. You may take pieces from here, but you may miss this area. So cardiac biopsy was done, and then differential again was TB cardiomyopathy versus cardiac sarcoid. And typical location of the scar is high, no other signs of tuberculosis. Cardiac sarcoidosis was considered more likely. She was started on steroids, and after explaining the risks of flare-up of tuberculosis and follow-up 6 months, no episodes of VT or syncope. At that time, now it is many years of follow-up. She even came 3 days ago. So when should cardiac sarcoid? This is for an information as a workup of white QRS. When should cardiac sarcoid be suspected? Unexplained syncope, all except unexplained sustained second or third degree AV block in young adults, less than 55 years. Don't just go and put a pacemaker. There's no fun in putting a pacemaker when the underlying etiology is something else. You could as well give him steroids, give him a better life. And sustained monomorphic ventricular tachycardia and idiopathic dilated cardiomyopathy. Patients with extracardiac sarcoidosis, syncope or sudden death evaluation in the young. What is it? When do you suspect sarcoid? Any of these scenarios you suspect sarcoid. So all are correct for sarcoid. Then all are true for cardiac sarcoid except sustained VT has independent prognostic value for predicting mortality, which is very true. Almost half the patients have abnormal echo study. They present very late, unfortunately. That itself is a prognostic factor as well. That is true. LV dilatation is a strong independent predictor of mortality. That is true. The etiology of sarcoidosis is uncertain. Very true. AV blocks are the third most common cardiac manifestation, which is very untrue. AV block is one of the most common presentation of cardiac sarcoid in the young. So please evaluate further. Send these people to electrophysiologists for further care instead of just doing some pacemakers. All are true regarding the diagnostic test in CS. Myocardial biopsy often shows granulomas. PET scan detects active coronary cardiac sarcoid and can be an important tool in the diagnosis and monitoring of patients. MRI reveals frequent septal involvement. Delayed enhancement represents myocardium that has been replaced by fibrogranulomatous tissue. All are true. Myocardial biopsy very rarely shows granulomas, only in 20% of cases. Unless you go, you really struggle a lot, maybe 30%, but otherwise not. So this is wrong. Lastly, what is the fun if you don't show an ECG like this? This is a 47-year-old lady who presented with extreme fatigue but alive. What is this? What was the first slide with workup that I mentioned? Blood test, metabolic causes. This is a sine wave pattern, very classical of severe hyperkalemia. Fortunately, patient was okay. We dialyzed her, fully recovered, and fine. Always remember, wide QRS, think of metabolic causes and drugs. So remember, guys, ladies and gentlemen, and junior colleagues, and the intellectuals who are hearing and want to be electrophysiologists, do not panic, and first do no harm. And with this, I think we come to the end of my talk. We can conduct a small quiz to learn a little further, maybe about 15 more minutes or 10 more minutes. And for those guys who have not seen Professor Brugada, this is how he was. He's much older now. And thank you very much. Shall we go for the quiz now?
Sir, just before that, can we just for 2 minutes go for a localization once again? Somebody has asked on a basal crux VT. Like in some fast, we can go to just localization once before connecting to the.
Yes. So when we say crux VT, we are referring to the inferior most part of the heart. Okay. So this one, inferior most part of the heart. This is where we are. But how do we differentiate between basal and apical? Basal, anything basal, you expect the forces to travel towards the chest leads. So V2 to V6 will be positive. If it is apical crux VT, then V5, V6 will be predominantly negative, right? Apical, because the forces are moving, the conduction is away from the V5, V6 area. The area that V4 to V6 cover is apical. How do you differentiate apex from base? Is this. V4 to V6 negative is apical, V4 to V6 positive is basal, and crux usually has a crux and the summit VT. It's not just the crux. Crux is inferior most. The superior most is also is the summit that also has a pattern break, pattern on ECG, and this is how we see. I think I have one more ECG in the quiz probably, which we can touch upon. Okay, and this is not, of course, the summit, because summit would have a inferior axis, but here it's a superior or a leftward axis, right? And it is very narrow because it's coming very close to the septum. So how do we go to the quiz?
Deepak, you can on the quiz.
Okay. I will pass this question.
Yeah, can you just yeah, you can maximize Deepak.
Yeah.
Yeah.
Can we start from the beginning?
Yes, sir. I think we can go to the main ECGs once, sir, so that we can learn also from that. Deepak, Deepak, you can go to the next one.
No, the first one. It's in order,
yeah.
right?
Yeah, this one.
This is not the first one, right?
This is the first one.
This is question 7. Question 1. Yeah. Okay. That's good.
Yeah. Yeah, this one is. Yes, sir.
So we have about 30 seconds for
yes, sir.
voting. Okay, that's good. Why is it just going? Why is it just going? Please.
I will want to quiz, sir. What is the rhythm?
No, this is not the question. The first question is different. Why is it just going?
Deepak, just go 2 questions back.
Let us do that, yes.
Yeah. This is the first question, sir.
Yes, please stick to the questions.
Yeah.
Now, what is seen in the following ECG? Capture beat, fusion beat, late diastolic PVC, sum of the above. Seconds for polling and then give me the result.
Yeah, I'll on the poll, sir. Yeah, the poll is open now. Yeah.
Time limit should be 30 seconds.
Yes, sir.
Yeah. Whether it's a capture beat, a fusion beat, late diastolic PVC, or none, or some of the above, not none.
Oh.
Somebody has edited, some smart kid. Okay. Medtronic.
No, me only, sir. Sorry. I sorry, sir.
It's okay. So.
Yeah, I'll stop the poll. Yeah.
Okay. So do we have the result?
Yes, sir. So majority are with fusion beat, 33 and 29. Close is late diastolic PVC.
Okay. So what we see here is a rhythm strip of V1. Okay. So there is a sinus beat followed by a couplet, 2 PVCs, and then 4 sinus beats. Then if you see the next P wave, the sinus beat is exactly coming on dot. This is regular. This is not a premature beat, right? So this is not premature, number 1. And there is again a couplet, but the first QRS is not a capture beat. Why? Because the QRS, this we know, if it was a captured beat, the QRS should have been like sinus. And this is too short an interval to conduct. Right? So this is in between a sinus and the PVC, so this should be a fusion beat. And that is correct. Fusion beat is correct. But then, what type of PVC is this? This is called a late diastolic PVC. Just before the sinus beat conducts, this PVC has come. It's a late diastolic PVC that gives an impression that this PVC is conducted. So these two are correct. So some of them.
Okay, I think so. Yeah, yes. I think by mistake I have done it like that. Yeah.
It's okay. Next.
Deepak.
Yeah. Next. So in the ICU, this is very practical, so I thought I'll keep it. Which lead would be best suited to monitor a wide QRS rhythm? Lead V1, lead V6, lead 2, or lead 3?
I'll open the poll, sir.
Yeah. What does it say? By habit, we have it, like always lead 2 is the default lead on monitor. So what is the result?
V1, maximum are with lead V1.
That's fantastic. V1 is to be followed. Next slide. Can you see the slide? Next slide. Yeah. So this is the reason why V1 should be followed. If you see lead 2, whether it is a left bundle branch block, RBBB, right ventricular tachycardia, left ventricular tachycardia, it almost appears the same, right? So if you have V1, you can definitely say whether it's LBBB, RBBB, RV, or LV tachycardia. So suppose you have a broad complex tachy and only lead 2 is there, you are just blind if you have lead 2. So have V1. Next. Very good. what is this rhythm? Based on whatever we have learned today, this ECG shows QR complex in V1 and a Q wave in V1 to V4. And then there is a broadish complex. Then there is a broad complex tachycardia. Now, what is it showing? So is it done? Are they seeing the options? Are they able to see the option? Is it a VT, which is AV because there is AV dissociation, there is axis shift, there's Q wave in sinus rhythm? Is it an SVT with a pre-existent right bundle branch block? Or is it a VT because of negative concordance? Or is it a left ventricular outflow tract VT because there is right bundle branch block with inferior axis? What is it? Have they voted already?
Yeah.
Sorry, sir. Yeah, the maximum is VT, sir.
Correct.
And second followed by LVOT.
Yes.
Yeah.
Okay. At least there are some who think otherwise. So I'll just give you why it is not a concordance. What does concordance mean? V1 to V6, all the complexes should be in one direction, either fully negative or fully positive. Negative or positive concordance. Here, you cannot call it a negative concordance because V1 is positive, right? Number one. So C is not the answer. SVT with pre-existing bundle branch block. Now, what do you think of that? Why is it not a SVT with a pre-existing bundle branch? If you see the AVR is a monomorphic R wave. Number one. If you see the other reasons why it is a VT, because there is AV dissociation, which we seen here. SVT will not have AV dissociation. Okay, there is something called, in lead 2, you can see the P waves coming out in some places, like I'm pointing out. So there is AV dissociation. Then, what is the other rule about axis that we taught? We learned axis shift of more than 40 degrees from baseline. There is the axis shift of more than 40 degrees. This says there's a VT. And when in a patient, look at the sinus beat, if there is a Q wave in the ECG and a QR during a VT, it localizes the V. It points more towards a VT. That means there is a structural heart disease. So there is AV dissociation. The A is the right answer. Okay. Look for AV dissociation. There is no SVT with AV dissociation. Of course, if you take an electrophysiologist, and then you can, but other things are against it. Right. This is not an SVT by any stretch of imagination. Next. Now the next question is next. Yeah. Where would you ablate this tachycardia? Here we have an ECG. The choices are wrong. Okay, here we have an ECG which has inferior axis, very positive in 2-3 AVF. Transition is between V3 and V4, monomorphic. This is a VT because you can see this AV dissociation. See this P wave here? Compared to these end, there is a P wave here. If you want to see in lead 2, there is a P wave here. Can you see that? This is a AV dissociation. So it's a relatively narrowish wide complex tachycardia. Means it is coming closer to the septum. It is coming closer to the septum. There is a VT with inferior axis. transition in V3 to V4, such amount of positivity, what is it? Is it a LVOT VT? No, please. Is it a LVOT VT? No, choice please. The options. Can you show me the options? Yeah. Is it a right anteroseptal area, right-sided axillary pathway? Because AV dissociation is not seen. Is it a left lateral mitral annulus? You ablate there because it is right-sided axillary pathway mediated antidromic tachycardia? Or is it a right ventricular outflow tract RVOT? Where do you ablate? AVOT, right paraseptal area, RVOT, or left lateral mitral annulus?
Shall I hold, sir?
Yes, yes. Some of you who are well read may feel this is too much stretching the imagination, but then you have to stretch it to reason it out.
Yeah, I stopped the poll at 30 seconds, sir. So the majority went with RVOT, right ventricular outflow.
That's fantastic. That's fantastic. If it is a left-sided angiotomy tachy, we would have a right bundle branch block, right? And you can see the ECG. And then there is obvious AV dissociation that has shown. You have to be very careful. One AV dissociation is enough for us to see, right? So there is a A that is different. So AV dissociation is there, and AVOT, well, it could be that is known only after X-ray. In a transition in V3, in a tachycardia with transition in V3, it could be also, LVOT tachy exiting through the RV or whatever. For what we know by ECG, it is good enough to say we ablate in the RVOT. That's fantastic. Okay, right. Next question, please. Where's the ECG? Yeah. What is this rhythm? What is the rhythm shown? Okay. Let them also be able to see the ECG. Take some time.
Yeah.
AF with aberrancy, monomorphic VT, polymorphic VT, pre-excited AF. So where are we?
Yeah, I'm closing the post area. Yeah, I think the good number went with pre-excited AF.
Okay. So let us explain for those who did not get it, or those who guessed it, or those who thought it is a VT. Now, if you say it is a polymorphic VT, it is, you may think, here the complexes are small and here it is bigger, so it is twisting around the point, etc. But you should see that the baseline itself is moving, and this is a respiratory artifact. And because there's a respiratory artifact, it is appearing like this. Okay? So this is not a polymorphic VT. Now, is it monomorphic VT? Why is it not a monomorphic VT? If it is a monomorphic VT, the cycle length variation is, even if it is there in the initial phases, not after settling down, it's in the order of about 30-40 milliseconds or that. And here you see almost 100% variation in the cycle length. It is so narrow here that it is quite wide here. So this is like a consulting, that is like there is grouping and going out. This is not typical of a monomorphic regular VT, right? So monomorphic VT is not the choice. Now, AF with aberrancy. Why is it not AF with aberrancy? Aberrancy means what? When the rate increases, the conduction gets slower. That means the QRS gets wider or broader. For example, see here, this QRS, here the rate is higher, right? This QRS, when the rate gets faster, should get broader because of more delay in the conduction. But it gets narrower, and when the rate slows down, it is broader. Correct? This is against aberrancy. Aberrancy means when the rate is higher, QRS is broader. This is very classical of a very interesting case of a pre-excited AF. Means the atrial fibrillation is being conducted over the pre-excited pathway, right? And this is how it is. And good, a lot of them got it. These are very interesting ECG. Next one. Okay, where is the origin of this tachycardia? Okay, there is a broad complex tachycardia, and there is poor progression of R waves in V4 to V6. The inferior leads are suggestive of a leftward axis, and I'm sure that this is a is this a VT or not? Let us see. There is definitely AV dissociation. If you see this complex, if you scan the ST segment between the RR, the segment between the RR, you can see the variation. It is not constant, right? That means there is AV dissociation. If you scan here, there is something here, and so there is AV dissociation, right? Now, is this what is the where is the origin of this tachycardia? Is it the RV inflow, means around the tricuspid valve? Is it the LV summit? Is it the LV crux or the RV out? So two LV origins, two RV origins. Now let us poll.
Sir, sir, we started poll. We gave 1 minute, sir. Sorry.
Oh, very good. Okay.
So a majority answer came from LV crux.
Beautiful. So this is fantastic. Why is it not RV outflow or LV summit? These two are outright ruled out because the axis is leftward. If these were the if B or C, it would be inferior axis. So now we are left with right ventricular inflow and LV crux. This is a pattern break, is very classical of a crux. You see V1 negative, V3 negative, suddenly V2 is positive, right? This is a pattern break. And if it was RV inflow somewhere on the tricuspid annulus, the QRS would be very wide and notched, which is not, okay? And now if you see, a pattern break is classical, and which part, this will answer the earlier question. Is it the basal crux or is it the apical crux? How is the V4 to V6? V6 is, more negative, right? V6, V5 and V6 are more negative, so it should be the apical crux. Is it clear? Fantastic, but I have got it. Okay, next. So, okay. What features suggest epicardial origin of this VT? Okay, this is a teaching point. I have already said this is epicardial origin. So there is no doubt that this is a VT. I have already said because I know the case also. Now tell me, what are the features? Can we show the?
Yes, sir.
Is it because there is a QS in lead 1? Is it because there is a pseudo delta wave more than 34 milliseconds? Is it because the intrinsic deflection is more than 85 milliseconds? Pseudo delta is this one, something that appears like a delta wave. Intrinsic deflection means from the origin to the peak. Is it more than 85 milliseconds, or is it because maximum deflection index or MDI is more than 0.55? That means in the lead which has a prominent pseudo delta wave, you measure the pseudo delta versus the QRS complex. If it is more than 55% of that, then it is suggestive of epicardial. So which of this, or is it all of the above? I'm sure most of you would have got it. It's a very august, intelligent audience going by the previous answers.
And majority went with all of the above, sir.
Absolutely. This was just a teaching point. I'm sorry I didn't keep very complex ECGs, but I think it's a good revision of, you can read on localization of post-MIVT. If you type it, you can read some articles on, now go to PubMed and find out and read it. These are some real life issues. I thank you all, and anything else? I think it's already past time.
I think we have covered all questions also, sir. Like in this polling session, almost all questions are covered. Deepak, the questions are left.
Thank you very much, Metronic and Sudhakar. More importantly, you've done a fantastic job. I mean, I've been in this field for 10 years, and you're really very impressive.
Deepak.
Yeah. All the questions have been answered.
Yeah.
You can conclude.
Yeah. Can I get out?
Thank you, sir. Thank you for very elaborate and recently very presentations to have explained very clearly to the audience. Thanks a lot for that. Thanks also for being here and forwarding the.
Yeah.
Thank you, sir. I'll call you back. I'll call you back once you reach home, sir. Yes.
Yeah. Tomorrow we'll catch up probably. I'm done.
Sure, sir. Okay.
Thank you.